Hello, everyone, and welcome to Let's Talk Conversations about Women's Health. This is a lecture series created by the Ludeman Family Center for Women's Health Research in partnership with UC Health, for which we are incredibly appreciative. We're delighted to bring you this special program virtually. With women historically excluded from research studies, there is a real dearth of knowledge about women's health, and as a result, there's a lot of work to do to catch up. The center studies women's health and sex and gender differences, particularly the areas of cardiovascular disease, diabetes, and the intersection of mental and physical health. The Ludeman Center is committed to a future in which research includes women and men and accounts for sex and gender differences. We do this through research, by mentoring and training, and through educational events. 10 years ago, the Let's Talk program was created to educate the community about health through evidence-based talks. Each of the lecture series is uniquely created and presented by scientific and medical experts. This evening, we will be focusing on autoimmune diseases. We have a fantastic speaker lineup with Doctors Kristen Demoruelle, Shah, and Marisa Stahl. Please type any questions you have for the speakers into the Q&A window. There will be a moderated Q&A session following the three talks. Tonight's program is being recorded. Recordings of past events and additional resources can be found at ludemancenter.org. We'll be sending out an evaluation after the talk. We really appreciate your feedback because otherwise we won't know what you, the audience, would like to hear in terms of additional areas. And we'd like also to hear what you think about each program. We really appreciate it. We encourage you to tune in to the worldwide live stream of our annual community event at noon Mountain Time on October 5th. In addition to learning about the progress at the Ludeman Center, renowned cardiologist Dr. Jennifer Marisa will speak about Heart Smart Solutions for Health. The next Let's Talk event will be in early December. And I have to remind you, I get to do the housekeeping and the general announcements. Please mute your microphone when you are not speaking. Speakers will be in charge of sharing their slides on the screen as well as stop sharing and unmuting their microphones. I'm very pleased to welcome tonight a great lineup of speakers. Tonight, our first speaker is Dr. Kristen Demoruelle, MD, PhD. Dr. Demoruelle is an associate professor of medicine in the Division of Rheumatology. She's a scientist at the Ludeman Family Center for Women's Health Research. She's a rheumatologist in particular whose research focuses on understanding what causes rheumatoid arthritis-related antibodies to develop and how rheumatoid arthritis affects women. And in fact, why women get rheumatoid arthritis much more frequently than men. So thank you, Dr. Demoruelle.
Thank you very much for the kind introduction, Judy, and thanks to the Center for inviting me to talk today about this topic that I think is very important. So, okay. I'll start by just introducing what an autoimmune disease is in general, and then I'll talk about some sex differences in autoimmune diseases, but specifically focused on rheumatoid arthritis and lupus, which are two diseases that I take care of. So just to get everybody on the same page, kind of to start, what is an autoimmune disease? Well, it's diseases in which the body's immune system start to attack itself. These are often, but not always, mediated by antibodies. And if you're not familiar with the term antibody, that's a protein that's produced in response to another protein. So antibodies are generally helpful, particularly in infection. A very timely example that I can give you is that if you get infected with COVID-19, your body will make antibodies in response to proteins on COVID-19, on the virus. And these antibodies can bind and clear the infection, which is obviously helpful to you. Your body does this similarly for other types of infections. It makes different antibodies that target proteins of other infections. And so this is obviously a good thing that your body does. In autoimmune diseases, though, the immune system gets a little bit mixed up for reasons that we don't completely understand. And these antibodies start to target proteins that are your own body's proteins. So when these antibodies target your own body's proteins, they can bind and cause inflammation and injury that can lead to tissue damage, resulting in various types of autoimmune diseases. There are some autoimmune diseases that are localized to a particular organ or tissue. A few of those are listed here, and you'll hear more about some of those in later talks. For example, multiple sclerosis, really targeting the brain and nerves, celiac disease targeting the gut. There are systemic autoimmune diseases that can affect many different organs, and those are things typically taken care of by rheumatologists. Those include rheumatoid arthritis and lupus, which I'll talk with you a little bit more about. So rheumatoid arthritis is an autoimmune disease, and the immune system primarily targets the joints in this disease. Often it affects the hands and the wrists, and you can see this picture here of an individual with rheumatoid arthritis causing inflammation in their hands. The symptoms people tend to have are swelling, pain, and stiffness in their joints that are affected. And for some people, unfortunately, it can really lead to severe joint damage and even disability. While we do have some treatments that prevent these things from getting this bad, it's still a chronic disease, as we'll talk about, and there's a lot of headway to make in the treating the disease that we hope to be moving forward over the next decades. RA can affect the lungs, heart, and eyes as well in some individuals. Lupus is a little different. The immune system also targets different organs, but a variety of different other organs. The skin, kidneys, brain, lung, heart, and joints can be affected. Lupus can really range from some people who have very mild disease, maybe they only have a skin rash, and some people can have very severe disease with kidney failure or seizures caused by lupus. And the pattern of which organs are involved really differ from patient to patient. In both rheumatoid arthritis and lupus, we really don't know what causes the disease, and we think it's probably a combination of a lot of different things. You may have heard, but most autoimmune diseases, there's likely an underlying genetic risk that a person has. This may be a genetic risk that either changes your immune cells, or it may just change the way your immune cells respond when they're activated. Genetics alone isn't usually enough to cause an autoimmune disease, and not the case with rheumatoid arthritis or lupus. And so we think that there are other things that are involved as well. Certain external triggers, which in rheumatoid arthritis and lupus, there have been some studies to suggest that certain infections, certain dietary factors, and smoking can increase the risk for developing these diseases. And so we think they probably contribute in this way where multiple different factors are playing a role. There's also female-specific factors, and we'll talk about how women develop RA and lupus more often. And so things like sex hormones, sex chromosomes, and pregnancy may also have an influence on causing these diseases. There's probably also unknown factors that we don't yet know, that there's a lot of research trying to understand what causes these diseases, but likely a combination of different things that ultimately lead to someone developing one of these autoimmune diseases. I'm going to briefly mention these three areas of sex differences in RA and lupus. One of the most perhaps interesting things with RA and lupus, and many autoimmune diseases for that matter, is that they often affect women more often than men. So rheumatoid arthritis and lupus affect about a little less than 2% of the population. But when you look at the breakdown of the number of women compared to the number of men affected, in rheumatoid arthritis, it's about 3 times more common in women than it is in men. And it's up to 8 times more common for lupus to affect women compared to men. What's really interesting also is that this difference between the number of women and men that get these diseases also seems to be different at different ages. So if you look at this figure from rheumatoid arthritis development, this is people who developed rheumatoid arthritis. So this is like the incidence or how many people developed rheumatoid arthritis. The light blue is women and the dark blue is men, and it's broken down by different age groups. This is this ratio, again, the female to male ratio. So in these younger premenopausal age women who are less than 50, it's almost 5 times more common in women compared to men at these younger ages. It's still more common in women than men in older postmenopausal aged women, but you can tell that it's a bit less. And this is somewhat similar in lupus, although the breakdown in this particular study is a little bit different. But you can see that the female to male ratio is much higher in these younger people compared to in the older individuals, while still more common in women than men, not quite as much so. And so this really suggests that there's something about the immune system, particularly in premenopausal aged women, that is making them more prone to these autoimmune diseases. One thing that it's quite interesting is that the immune system is different in women and men. And in kind of broadly summarizing a lot of different things, in general, women have a more robust immune response. So there are cells in your body called T cells that help you fight infections. And when they look at those in women compared to men, T cells in women are just more easily activated. Estrogen, which women have higher levels of, stimulate B cells, which are the cells in your body that produce these antibodies we were talking about. And so women compared to men at baseline, just healthy people, women have higher baseline levels of antibodies compared to men. So all of these things together give women a more robust immune response, which results in better protection against infection. But unfortunately, it's also a more robust immune response. And when that goes wrong, it can increase the potential for an autoimmune response. In addition to those things, there's pregnancy, which is unique to women. And there are several things to note that are different in women with rheumatoid arthritis and lupus as it affects pregnancy. There are a couple of risk factors for developing rheumatoid arthritis that are specific to pregnancy in women. For example, the postpartum period, or that first year after a woman has a baby, that's actually a really high risk time for a woman to develop rheumatoid arthritis. Lack of breastfeeding, that's really that breastfeeding has been shown to decrease the risk of rheumatoid arthritis. And so conversely, a lack of breastfeeding may increase a risk. And there's something called preeclampsia that's a pregnancy complication that some women have during pregnancy that can increase the risk for developing rheumatoid arthritis. Also in women who have rheumatoid arthritis, if they are pregnant, a lot of times their rheumatoid arthritis symptoms get much better during pregnancy. Unfortunately, postpartum, after they deliver the baby, there's a high chance for them to have a flare. And so clearly pregnancy has an effect on the immune system that impacts rheumatoid arthritis. In lupus, one of the pregnancy-related issues is unfortunately that many women, up to 64% who have lupus, will have a pregnancy complication such as a miscarriage, premature birth, preeclampsia, or postpartum infection. And so unfortunately in lupus, there is not a clear benefit that their lupus gets better when they're pregnant. And unfortunately, they have a high chance for having these pregnancy outcomes. So again, lupus really having an effect on the pregnancy. There's also something unique to lupus patients that a small percent of them, only 2 or 3%, but they can have their the antibodies that they have related to their lupus can actually cross the placenta, and as a small number of cases can affect the baby. It can lead to skin issues called neonatal lupus, which is shown here, and that usually goes away. Unfortunately, there is a heart complication that can occur that is more permanent. And so women with these diseases have some unique considerations for pregnancy. Cardiovascular disease is something that the risk for cardiovascular disease is increased overall in rheumatoid arthritis and lupus, about 2 to 3-fold higher in rheumatoid arthritis compared to the general population, and about 4 to 10-fold higher risk for cardiovascular disease in lupus patients compared to the general population. This is just a figure to kind of show you that in rheumatoid arthritis, over time, there continues to be higher mortality in patients with rheumatoid arthritis compared to this line here is the general population. And a large portion of this increased mortality risk, unfortunately, is from cardiovascular disease. What's interesting is that traditional risk factors that you think about for cardiovascular risk, like smoking or high blood pressure, high cholesterol, while also important, don't explain all of this increased risk. And so there's probably something unique about rheumatoid arthritis and lupus that increases this cardiovascular risk. As it relates to sex differences, it's typically the case that premenopausal women are protected from cardiovascular disease. And unfortunately, in these autoimmune diseases, it appears that premenopausal women lose this cardiovascular protection or cardiovascular disease protection. And so they're disproportionately affected by this increased risk for cardiovascular disease. As I mentioned, we don't know what causes rheumatoid arthritis or lupus, and so unfortunately that means we can't cure it, but there are some interesting things to tell you about along those lines in trying to get to that point. It's thought that maybe we start treatment too late. So there's been some important findings in both RA and lupus over the last few decades that antibodies are actually present years before the disease develops. And so we think if we can figure out where these antibodies originate from, maybe we can prevent the disease. I'll show you this figure to show you in rheumatoid arthritis. This is patients with rheumatoid arthritis. So they developed rheumatoid arthritis at this time point 0. And in this particular study, people had blood that was stored for years before they got rheumatoid arthritis. And you don't need to know these different antibodies, but these are all rheumatoid arthritis related antibodies. And you can see that up to almost 50% of them Again, they got rheumatoid arthritis at this point, and on average, 3 to 5 years before the arthritis, they actually had these antibodies present in their blood. So something is sort of dysfunctional in the immune system before the arthritis even begins. So when we think about where these antibodies come from, you might initially think they would come from the joints because that's what's targeted in rheumatoid arthritis, but there's really no inflammation in the joints at the time point that we see these antibodies in the blood. And so we now think that it's probably mucosal sites, perhaps the mouth, the lung, the gut, the urinary tract, where your body is constantly having interactions with the immune system and the environment, and that maybe inflammation and antibody generation at those sites actually is the initial kind of inflammatory process that starts, and later it develops into the arthritis that we call rheumatoid arthritis. So my research focuses on the lung and female genital tract as two potential mucosal sites where this may occur. And I'll just briefly mention a little bit about that here. A couple of studies we've had now have basically shown that we can find these antibodies related to rheumatoid arthritis in the lung. This is just a figure with some healthy controls, some people with rheumatoid arthritis, and people who we have found to be at risk for rheumatoid arthritis based on either blood testing or family history. You could see that there's a portion of them that have these antibodies in their lungs when we test them. And so we think this shows us that in some people, there is RA-related antibodies in the lung, and that may be an early sign of the development of the disease. I'll take a second to talk about why I got interested in women's health research at this point. And so many of the patients that I see are young women with a chronic life-altering diagnosis, and that can be tough. And I like trying to help women through this tough time in their life. With that, we've actually started a new rheumatology women's clinic at the University of Colorado Hospital, specifically to address unique issues that women with rheumatic disease face. And I'm really happy to be a part of that. We're really focusing on pregnancy planning and contraception, which are issues that affect all women. But there are some unique issues that women with rheumatic diseases have to face related to the medications that they're on. And so this has been really exciting for me to move this forward. It also is not clear why women get RA or lupus more than men, despite decades of research. And so I really wanted to bring a new perspective to an old unanswered question. So some of my research now looks at the female genital tract as a potential mucosal site that women have that men don't have. And maybe this could explain why women have a higher risk for rheumatoid arthritis. So we looked at antibodies, whether or not antibodies were present in vaginal fluid. And so this is just a very sort of summary of things we're working on, where if we do the same thing we did in the lung, but we look in the female genital tract, you can see that these antibodies, which again, the specific name doesn't matter, it's just a rheumatoid arthritis related antibody, they're much higher in the female genital tract in women with RA, but also some of these women at risk for RA and even healthy women. And so we're now looking at what things are causing these antibodies to be generated at these mucosal sites. Is it changes in the microbiome? Is it contraceptive methods that can change inflammation at this mucosal site? I think overall what's really exciting is to think about women have this mucosal site that men don't have, and we really don't understand how it might contribute to the development of autoimmune disease. And so hopefully we'll learn more about that over the coming years. I'll finish up by saying, what's the future of treatment for autoimmune diseases? I think we hope that eventually we'll be able to prevent them. And I'll briefly mention a study at the university called Stop RA, where it's enrolling people who are at risk for rheumatoid arthritis based on a blood test and giving them a medication called hydroxychloroquine versus placebo to see if we can prevent rheumatoid arthritis in these people who are at risk. This is a medication that is a systemic medication. And so ultimately, as I mentioned, these mucosal sites and antibodies, hopefully we can actually target very specific sites in the future where we can maybe stop that antibody generation very early on. If you're interested, this is a number that you can call and get tested for this RA-related antibody, anti-CCP. We've got several studies in addition to that prevention study, that are observational studies to try to understand these diseases more. And so I'll just summarize by saying, most autoimmune diseases are more common in women compared to men. And unfortunately, we don't really understand why. And hopefully we can make headway on understanding that over the coming years. There are some unique features of pregnancy and cardiovascular disease that are unique to women with RA and lupus. These early steps in the development of RA and lupus may begin with inflammation, antibody generation, and mucosal sites. And one day I really do think that we'll be able to prevent RA and lupus by targeting this early antibody generation that occurs before the tissue damage in the joints and rheumatoid arthritis, for example, that we associate with the disease. I'll end by thanking all the participants in our studies, our research team. This is my research team here, all the funding, including from the Ludeman Center, that's been very supportive of my research. And I'll turn it over to the next speaker and be around later for questions. Thanks. I think you might be muted, Judy.
Thank you, Kristen. That was a great talk. And I already have questions for you from the audience and from me. So watch out afterwards. Sorry. Thanks a lot. That was really great.
Thank you.
Our next speaker is Dr. Anna Shah. And let's see. Are Dr. Shah's slides, or you're putting your slides up? She completed a year of fellowship in neuroimmunology, multiple sclerosis at the University of Colorado. She's an assistant professor in the Department of Neurology. She has a special interest in how multiple sclerosis affects women, particularly in the areas of pregnancy, breastfeeding, and reproductive health. Dr. Shah works with patients who have multiple sclerosis at her clinic at UC Health. This is very interesting. This is, a condition that is more prevalent, I believe, in Colorado, but we'll see what Dr. Shah says. And thank you, Dr. Shah.
Absolutely. Thanks for having me. As Judy mentioned, my name is Anna Shah, and I'm one of the neurologists at the UCH Neurology Clinic at the Rocky Mount MS Center. So what we'll be doing today is exploring the impact of women's health as it relates to multiple sclerosis. So we'll spend the first 5 minutes or so talking a little bit about basics of MS or multiple sclerosis, including what it is, the epidemiology of it, and then we'll kind of get into what I call the meat of the talk, or the women's health and how it pertains in multiple sclerosis, looking a little bit at sex hormone differences, particularly focusing in on pregnancy, the postpartum period, impacts of breastfeeding, as well as the perimenopausal period. Finally, we'll end with some socioeconomic implications on women with multiple sclerosis, just because I think they're incredibly fascinating to think about. So let's talk a little bit about what multiple sclerosis is. Now, what I'm showing you here is what we call a nerve cell or a neuron. That top picture that you're seeing there is really what a normal neuron should look like. And it's easiest to think about it kind of like being a wire. That light tan portion you're seeing right here is kind of like the wires that go through a wire, and we call that the axon. That's what controls a lot of our nerve signaling. This more yellow portion right here is what we call the myelin, kind of akin to the insulation around a wire, and that's what let our nerve signals go faster. So when we look at this bottom picture, that's an illustration of what it looks like in multiple sclerosis, where the autoimmune system or the immune system is really attacking that outer myelin or that insulation of our nerve cells. When that outer myelin is attacked, it tends to unravel. It causes area where there's exposure of this underlying wire, and it causes impairment of signals. So if we look at this, this is another way to kind of look at the same thing, but we're looking at a completely healthy nerve cell or neuron there on the left, and on the right is what our nerve cells look like in the state of multiple sclerosis. So what you can see is there's these damaged fibers, those inner wires are exposed, which means the signal, instead of going through clearly, all robustly at once, it ends up being a disrupted signal. So where does MS affect? And I think this is probably one of the most common questions I get asked, so I thought it was worthwhile spending just a minute on it. This is an illustration of what our entire nervous system looks like. You'll see something divided in red or in orange, which is what we call the central nervous system, and the yellow is our peripheral nervous system. Now, multiple sclerosis is unique in that it is an autoimmune disease that only really affects our central nervous system, so our brain and our spinal cord. The rest of the nervous system actually, interestingly, is not affected by multiple sclerosis. So when you hear someone say, gosh, I've got a pinched nerve, or I have neuropathy related to my diabetes, those are all areas of the nervous system that aren't actually affected by multiple sclerosis. So what does multiple sclerosis cause? What does that damage cause that we looked at? When patients with multiple sclerosis have a brand new neurologic symptom, we call that a relapse. And here's just a fun pictorial diagram of different symptoms that can really occur in MS, ranging from mood issues, increased rates of anxiety, depression, weakness or loss of muscle strength. It can cause abnormal sensations, sometimes feeling like pins and needles, sometimes like jolts of electricity. It can also cause vision issues. So we usually hear about double vision or loss of vision. Fatigue is probably the most common symptom described in MS. Over about 80% of our patients reporting that at some point. Muscle tightness or spasticity, difficulty with walking, often requiring something to help walk, dizziness, and then bowel and bladder issues are also very commonly described. And this is just kind of the tip of the iceberg in terms of most common symptoms. Now, how does MS get diagnosed? Unlike some of the other disease states that you hear about being autoimmune, there's not a clear blood marker or an antibody test that we can do. So we use a constellation of kind of three different categories or three different features to kind of make a diagnosis of MS. One of that is clinical history. Do the symptoms you're having sound consistent with multiple sclerosis? The second is taking very detailed pictures of that central nervous system we're describing, the brain, and then the spine. And then the third piece that we also can do is take a small sample of the fluid in a process called a spinal tap or a lumbar puncture to look at that fluid and see if there are markers of inflammation in that fluid. Now, how common is MS and why are we talking about it today? So the most recent estimates we have for the incidence or the prevalence, of multiple sclerosis in 2010 was about 727,000 cases. Now, I think the most interesting part of this slide is saying 7 years later, that number had increased by 200,000 cases. Worldwide, we estimate about 2.8 million people with multiple sclerosis, although I think that is probably a significant underestimate just because of lack of subspecialized neurologic care available. Here is an interesting map of the United States that really illustrates what is the frequency or how often is multiple sclerosis occurring in different regions. Unfortunately, we don't have the best numbers about what each individual state looks like. We do globally tend to see an increased rate of multiple sclerosis in the Midwest. However, within the western part, the pink part that we're looking at, in Colorado, we actually estimate about 1 in 400 individuals having a diagnosis of MS, which is quite remarkable when you think about it. Who exactly does MS affect? MS typically affects those, they're usually diagnosed between the ages of 20 to 45, and I would say that makes about 80% of our population, although it can certainly affect individuals on either side of that age range. It tends to affect females by up to 3 times more, and part of that is thought to be related to sex hormones like estrogen and progesterone, which we'll talk a little bit more about in just a second. We also tend to think about multiple sclerosis as being a disease that primarily affects Caucasians, particularly with those with a Northern European lineage. Although with increased globalization, I'm not sure that that's necessarily quite as robust as it once used to be. And we do think there's a component of genetics that causes individuals to be at a higher risk of getting MS or being diagnosed with MS. Now, just to put that into perspective, it's not a typical inherited disease where if mom or dad has it, the child is going to get it, but it does increase the risk from about 0.13% to maybe 2 to 6%, depending on the study you're looking at. So where does women's health tie into with MS? So I'm going to take us back to just a very basic understanding of the immune system. And I promise I won't go crazy in depth with this, but I'm just going to point out a couple of things. This area on the right is what we call our adaptive immune system. And that's the portion of our immune system that really says, gosh, I've had this infection before. I'm going to remember that and make a targeted response to that infection. The cells that are really important really come into play when we're talking about multiple sclerosis is we look at the subset right here called T helper cells, and you'll notice there's a 1 and a 2. These become important, especially as we start talking about sex hormones, because we think these Th1 cells are really what is causing a lot of this damage, a lot of that destruction of that insulation or myelin in multiple sclerosis. Now, the body has natural ways of counteracting that, and that's primarily with those Th2 cells and also these T regulatory cells that you're seeing here in the middle. You'll also hear me kind of mention these B cells that are over here, and that's because a lot of our really effective immune treatments that we use to treat multiple sclerosis are targeting these cells over here. Now, where do the sex hormones play into this? Now, we think in general, the increased amounts of estrogen, increased amounts of progesterone tend to favor the Th2 cells or the T helper cells that are the subtype 2. And that becomes important because, as we know, in pregnancy, we tend to see an increase in those sex hormones in things like the postpartum period and things like menopause. We tend to see a drop in those, which kind of correlate to what multiple sclerosis disease activity looks like. So let's start talking a little bit about multiple sclerosis in pregnancy. I think probably the most common questions I get asked include those on this slide. So multiple sclerosis does not have an impact on fertility, on the ability of a woman to get pregnant or the ability of a woman to carry her child. Multiple sclerosis does not increase the risk of miscarriages. It does not by itself increase the risk of birth defects. There's also no limitation on the type of anesthesia a woman with multiple sclerosis can have during childbirth, whether that be an epidural or spinal anesthesia. And we talked a little bit about the genetics. And so we know a first-degree relative or a woman having a child with multiple sclerosis puts her child at slightly higher risk, but it's not what we typically think about when we think about passing on the disease. Now, what do we know, or what is important for our patients with multiple sclerosis to know when they're thinking about planning pregnancies? There has been a registry-based study that showed women with multiple sclerosis had babies that were slightly smaller or slightly less in terms of birth weight compared to women that did not have MS. And there also tended to be a trend towards more frequent inductions and operative intervention, things like cesarean sections or C-sections during delivery. And part of that, maybe it was associated with times where those women with multiple sclerosis might have been what we considered more severe or had more significant neurologic deficits. What does pregnancy look like in multiple sclerosis? So we think of pregnancy really as a stabilizing period. In fact, one of the most robust registries we have or studies we have in pregnancy in multiple sclerosis is something called the PRIMS study, which was Pregnancy in MS study. And they actually found that the relapse rates during the 3rd trimester of pregnancy is about 70% lower than what they were like before they got pregnant. And I think that becomes really important because we say, well, gosh, we know our estrogen and progesterone, our sex hormone levels really increase at the greatest level during that 3rd trimester. One of the things you'll hear me allude to quite often is something called disease-modifying therapies, also known as DMT. In multiple sclerosis, that's referring to medications that we're using to manage the inflammation or the damage done with the disease. As of right now, we have over 20 different disease-modifying therapies in multiple sclerosis, which is phenomenal. It's important to think about because they're not all necessarily built the same. And what we're really trying to do is expand the range of DMTs or disease-modifying therapies that are available for women during pregnancy. Now, in the postpartum period for multiple sclerosis, similar to what we were just talking about with the last speaker, there is an increased risk of clinical and radiographic, which means on imaging, new disease activity really in that first 3 months after delivery of a baby. The things that really impact how a woman does postpartum in terms of multiple sclerosis or new disease activity is how were they doing before they got pregnant? How were they doing during pregnancy? And what severity was their disease overall and what kind of disability did they have? Now, if we go back to that same study that we were just talking about, the PRIMS study, in that study, they found that the risk went up about 30% in those first 3 months postpartum to have a new neurologic sign. Now, there are some MRI studies that have actually been done in that same postpartum period where they found women might actually have new lesions or new disease activity on MRI scans up to 50 to 60% of the time, which is pretty significant. There is also about a 5-fold increased risk of postpartum depression and anxiety, and which I think really just bears to mind that this is a period that we should really be focusing on. And it's one of the areas that I really have been honing in on in terms of doing research. I think a really natural question might be, well, gosh, you said the hormones really help and the hormones drop off in that postpartum period. Why don't we use hormones as disease-modifying therapy or use hormones to stop women from having this increased disease activity? There were a few small studies that did exactly that, where they gave women in the postpartum period or women overall doses of hormonal replacement, particularly estrogen forms. However, what they found was women did okay in terms of inflammation during that period they were getting those hormones, but as soon as the hormones were stopped, it increased the disease activity once again. So it wasn't necessarily a long-term fix. And there is the increased risk of other cancer types associated with long-term use of those hormones. One of the things that we're also looking at is this DMT use in the postpartum period to see, is there a way for us to be able to do it safely and a way to prevent this increased risk of disease activity? And now that ties in really nicely with breastfeeding. What do we know about breastfeeding and disease activity in multiple sclerosis? So there has been a meta-analysis of 16 studies, which means that they took 16 different small studies, kind of put them together and said, what did we see? And they found that women that were breastfeeding had a 37% lower risk of relapses or disease activity if they were breastfeeding. And we really noticed this associated with what we call exclusive breastfeeding, meaning that the women were just breastfeeding and not using formula supplementation or things like that. Now that's quite limited because these were several small studies all put together to kind of overall look at the picture. There hasn't been a large study done for this, but I think it brings up a lot of areas where we can really hone in on and say, gosh, it's important for us to support mothers that would like to breastfeed with multiple sclerosis. It can have benefits on disease activity. And one of the particular studies that I'm doing right now is looking at safety of some of these DMTs in women that are breastfeeding, because of course we want to make sure baby is staying safe as well as mom. Now let's fast forward a little bit to menopause. One of the things that we know with menopause is we expect a decrease again in these sex hormones. And in multiple sclerosis patients, sometimes we see a slight increase in disability progression at this time. There's always been this question about, gosh, is it related to this drop in hormones? And I think it would be silly to say there wasn't any link. I think the other things that play a role in this slight increase in disability we sometimes see around the menopausal period is we tend to see a lot of hot flashes. Now, people or individuals with multiple sclerosis tend to be pretty heat intolerant. And the reason for that is those nerve signals slow down in everybody in heat, but particularly because there's damage in the myelin, slows down even more in multiple sclerosis. So these hot flashes cause something we call recrudescence, which is emergence of these old symptoms that's just transient or temporary. Those tend to make people feel worse and increase disability. We also think there's probably a component of aging. We all know as we have more birthdays, we tend not to tolerate things quite as well. And so there's likely a component of aging that goes in there. One of the things that I think is really interesting is there are trials that are being done right now really looking at saying if we use hormonal therapies around this menopausal period, what are we seeing? We have an animal model that we typically use, a mouse model for multiple sclerosis. It's called experimental autoimmune encephalomyelitis, which you don't need to remember, but it's important because in those animal models, we actually see an increased amount of myelin or that insulation being recreated when hormonal therapies are used in menopause. So I think it'll be really interesting to see if that translates into humans. So let's take the last few minutes to really talk about what are the socioeconomic implications for women living with multiple sclerosis. And this study that we have here was the survey done in 2017 that encompassed about 800 women in 8 different European countries. There has not been a similar survey done in the United States, but I think the results of it are pretty broadly applicable. In this study, about 21% of women were misdiagnosed with another condition before being diagnosed with MS. And I think one of the things that stood out the most of what they were misdiagnosed with was typically chronic fatigue syndrome, chronic pain syndrome, where there was actually about 10% of this 21% were actually told they were maybe making up their symptoms, which I think is a pretty resounding number. 41% of these 800 women were separated or divorced their partners after their diagnosis of multiple sclerosis, and 88% of them noticed that MS had played a role in that decision. 37% of the women surveyed in this survey had changes in family planning as a result of their diagnosis of MS. And that includes decision of how many children to have, when to have children, and even methods or how to have children. 66% noticed that MS had affected their employment at some point, and of those patients, about 38% had left employment altogether, which is a resounding number. 60 to 80% either lost their job or exited the workforce about 15 years after their diagnosis of MS. And I think what these survey results really illustrate is there is an unequal socioeconomic implication on women that are diagnosed with MS from a family planning standpoint, and particularly from a work standpoint. So perhaps really honing in on the period where most women are diagnosed, that 20 to 45 age range, I think can have significant downstream effects. So the conclusions of my talk here today. So MS affects women at a 2 to 3 times higher rate than men. We think perhaps due to the differences in sex hormones. Pregnancy is really a protective period for women with MS, similar to most autoimmune diseases. And there's an increased risk of disease activity in that postpartum period. There are also significant socioeconomic implications for women with MS, ranging from personal to social to financial. And I think really just good research and more available disease-modifying therapies will hopefully help mitigate the increased risk of disability associated with that postpartum period and our socioeconomic implications. So that's my talk. Thank you for listening. And I think you might be muted.
I'm muted, but okay, now I think I can share my screen.
Okay. Thank you very much. Again, we're going to have questions and answers right after this next talk by Dr. Stahl. Dr. Stahl is a pediatrician and a gastroenterologist at the Colorado Center for Celiac Disease at Children's Hospital at the University of Colorado. Her research focuses on celiac disease screening and diagnosis in children and Down syndrome. And her talk today is entitled Celiac Disease, What Women Need to Know. Thank you very much, Dr. Stahl.
Thank you so much for having me. And I know I'm the last talk, so I will try to keep this relatively short and sweet. I have some disclosures, none of which are related to the talk that I am giving today. By the end of this session, I would hope that you will be able to describe celiac disease and the varying presentations. We're also going to review sex and gender differences with respect to celiac disease incidence and complications. And then finally, we'll describe the sex and gender differences with respect to treatment response to the gluten-free diet, which I'm going to abbreviate on future slides as GFD. Celiac disease is an autoimmune disease that's triggered by gluten. It causes this characteristic intestinal inflammation that you can see on the slide here. On the left is the picture of a healthy intestine. Healthy intestines are lined with all of these finger-like projections called villi that are critical for normal absorption and nutrition. To the right here, you can see pictures that are affected by celiac disease. And you can really see the redness, the bumpiness, and the irritation, all of which are signs that these villi have been injured and flattened. Now we know that certain HLA genes are necessary to develop celiac disease, but 40% of the population actually has these genes, and only 1 to 3% of the population goes on to develop celiac disease. So there are clearly other environmental and genetic factors at play. So what is gluten? At a molecular level, it's this protein that's pictured on the right here, and that has really important consequences for the pathogenesis and some of the developing pharmacotherapeutics for celiac disease. But at a more practical level, it is the storage protein found in certain grains, and it's what helps kind of keep our food sticky. What you can see from the list on this slide is that gluten is really everywhere. And unfortunately, the only treatment that we currently have for celiac disease is a strict gluten-free diet. This slide is really just to show that celiac disease is a very common chronic disease that occurs worldwide. What's highlighted here are the results of the pooled seroprevalence from several different screening studies from around the world in a recently published meta-analysis. And the pooled worldwide seroprevalence of celiac disease was 1.4%. So that translates into more than 1 in every 100 people. So that makes it more common than type 1 diabetes, but not quite as common as thyroid disease. And once again, really, this is just to demonstrate that celiac disease is a very common problem worldwide. And it's an even more common problem in Colorado. So this is data from one of our studies here in Colorado that follows children at genetic risk of celiac disease and type 1 diabetes. And what you can see from this slide is that by age 10, 3.1% of these children develop celiac disease. Interestingly, while we know that celiac disease is a disease that you can develop at any time in your life, at least in this study, it seemed like the incidence of celiac disease plateaued after 10 years old. So what about sex differences in the incidence of celiac disease? So there was a meta-analysis that was performed to answer this very question in 2019, where, similar to the other talks today, they pulled together a bunch of screening studies and tried to estimate what the incidence of celiac disease was for women. And what they found was that women were almost 2 times as likely as men to have celiac disease. And they found a rate of undetected celiac disease of about 0.6% in women. So when they extrapolated that to the US population, they concluded that about 965,960 women in the US have undiagnosed and untreated celiac disease. So is this accounted for by differences in biology? The authors of this meta-analysis proposed some mechanisms, including pregnancy and menstruation effects on intestinal permeability, sex-associated differences in the immune function, and factors that may be modulated by sex hormones. As we are noting celiac disease be more common, we are also seeing that the spectrum of presentation is quite wide. Not really limited to the typical gastrointestinal symptoms that you may think of with a disease that affects the intestines. It's now about less than a third of patients that will present with these classic gastrointestinal symptoms, such as abdominal pain, diarrhea, bloating, weight loss, even constipation. What's much more common are the extraintestinal manifestations, and the spectrum is really quite broad. It can be anything from headaches and brain fog to mouth ulcers, to heart issues, to rashes, and to complicate things even more, a lot of people who are diagnosed have no symptoms at all. So what about gender-based differences in presentation? Some studies have found a difference in presentation based on gender, while others have not. Some studies have suggested that women are more likely to present with abdominal pain or iron deficiency anemia, or even osteoporosis. Interestingly, no studies have identified significant differences in concurrent autoimmune diseases at the time of presentation. But I'll also just point out some features of presentation that may be unique to women, such as amenorrhea, delayed menarche, early menopause, and fertility issues. I really like this table from a review article that focuses on celiac disease in women's health, because it summarizes the aspects of presentation which may be unique to women. And we are going to focus on these specific populations: women of childbearing age, women who are struggling with infertility, and women with low bone mineral density on later slides. At this point, you're probably wondering, well, she said celiac disease screening. What does that mean? At our center, we recommend blood testing for celiac disease for those who have the symptoms that I showed you on the previous slide, or a family history of celiac disease. And what that entails, and it's already been outlined so nicely in some of the previous talks in terms of what antibodies are, but the celiac antibody is called a TTG IgA antibody, and so we recommend getting that blood test. And then with that, you want to get a total IgA level. And I think this is where a lot of people get confused. The total IgA level is just to make sure that you are making enough of this IgA antibody that the TTG IgA antibody is a good screen for celiac disease. So we expect the IgA level to come back normal, or if it's high, that's okay too. If the IgA level is low, then we would want to send different blood testing for celiac disease. And this slide is just to show that celiac disease can have several complications when it's undiagnosed and untreated. And so that's why screening is important, because these complications are preventable with diagnosis and good adherence to a strict gluten-free diet. These complications really cross the lifespan and include, but are not limited to, certain dental enamel defects, poor growth, and these are the things that we worry about more in our pediatric population, but also osteoporosis and fractures and certain small intestinal cancers. So I'm going to take the rest of this talk to really focus on the areas of celiac disease presentation, complications, and management where there may be differences based on sex or gender. And so this includes fertility and pregnancy, osteoporosis, anxiety and depression, disordered eating, quality of life in the gluten-free diet, and then some other effects of the gluten-free diet. Untreated celiac disease has been tied to an increased risk of miscarriage. Some obstetricians will include celiac disease screening in their workup for recurrent miscarriage or infertility, although this is still pretty controversial. I think the other questions that come up when we are seeing patients in clinic from their mothers have to do with pregnancy and certain things which may help prevent celiac disease in pregnancy. And so there have been studies that have looked at the mode of delivery and the risk of celiac disease. And some have seen a difference for people that have had an elective C-section, with there being a later risk of celiac disease in the offspring. And the studies that found differences were retrospective studies. And when they actually followed people prospectively, they did not find an increased risk. The reasoning behind looking at this was really that the effects of a vaginal versus a C-section may have effects on early life microbiome. But once again, this has not played out in the larger studies. And then studies that have looked at interventions in pregnancy, such as reducing maternal gluten intake in the diet during pregnancy, have not actually reduced the subsequent risk of celiac disease for the baby. So I would say the take home from this right now is that there isn't anything with respect to how you deliver your baby or what you can do in pregnancy that prevents celiac disease for your baby. So what about pregnancy outcomes? There have been some studies that link untreated celiac disease to some poor pregnancy outcomes, such as prematurity and low birth weight. I think the very interesting thing about these studies is that they're all in untreated women. So I think the key here is that if you have suspicion for celiac disease, it is worth being screened and diagnosed and then going on a gluten-free diet, because one of these studies did show that the risk of prematurity was reduced for women that were on a gluten-free diet during their pregnancy if they had celiac disease. There have also been some other adverse pregnancy outcomes that have been tied to celiac disease, such as being small for gestational age. And the thought, once again, is that maybe when it's untreated, you're not having quite as adequate absorption of some essential vitamins and minerals during pregnancy that could be crucial for your baby's development. And along those lines, finally, just one study in Quebec looked at celiac disease and the risk of birth defects and found an increased risk of some heart and urinary defects. But once again, the very interesting thing about this is that the risk was higher in people who had previously required hospitalization for their celiac disease. So that once again speaks to the fact that potentially uncontrolled and untreated disease may be a higher risk for these poor outcomes. And then what about celiac disease and osteoporosis? So people with celiac disease are reported actually to have up to a 7 times higher fracture rate than the general population. And the reasoning for this reduced bone mineral density is probably multifactorial. It's because celiac disease causes inflammation, which can affect your bone health. But then it also causes specifically that intestinal inflammation, which can make it hard to absorb things like vitamin D and calcium. This occurs in men as well, but the effects on bone mineral density can also be affected by certain biologic factors unrelated to celiac disease, such as menses, menopause, and these effects are obviously more pronounced in women. Once again, I'll just emphasize that there is evidence that treatment with a gluten-free diet improves bone mineral density in those with celiac disease. And since our bone mass is really mostly acquired in the first 2 decades of our life, early diagnosis of celiac disease and adherence to a strict gluten-free diet, and then attention to adequate calcium and vitamin D are really the staples of ensuring good bone health in celiac disease. What about anxiety and depression in celiac disease? This is incredibly prevalent among newly diagnosed men and women. It's actually over half of newly diagnosed adults in some studies. There have been some studies that show that both anxiety and depression may disproportionately affect women at the time of diagnosis. But I think it's also, once again, important to point out that in these studies, anxiety and depression improved with the initiation of a gluten-free diet. And so I think regardless of the gender, the take-home message should be that comorbid anxiety and depression is really common in celiac disease, and mental health support is crucial for all genders. What about eating disorders? So several studies have suggested kind of a bidirectional relationship between celiac disease and eating disorders. Celiac disease can cause decreased appetite because of all the gastrointestinal symptoms, but then being on a strict gluten-free diet can also cause some people to have more disordered eating habits. There have been some studies that suggest that this is more common among women with celiac disease. And I think really the key part of this is that awareness of this association and early intervention, particularly among adolescents, is key. So what about quality of life? Several studies have shown that women may have more of a decreased quality of life once they go gluten-free for celiac disease compared to men. And one study kind of took a deeper dive into this and did multiple interviews in the way, try and get at the way women perceived the social consequences of the gluten-free diet and how they coped with this. And what they found was that at least early on, programs targeted kind of at togetherness and inclusivity and connecting with others with celiac disease may be more effective in women. So showing differences in coping strategies and adverse perceptions, but then also differences in kind of how that could be addressed and managed. And while initially it seems like their quality of life does decrease more after more time on the gluten-free diet, overall health-related quality of life does seem to improve. So what about the other effects of a gluten-free diet? So one meta-analysis found that there were certain increases in cardiovascular risk factors when on the gluten-free diet, increases in things like cholesterol and fasting glycemia and BMI. But this hasn't really been explored in terms of if there is a difference between men and women with respect to cardiovascular risk factors once going gluten-free. So I think that's an area of research that is needed. And then finally, there is an increased risk of certain vitamin deficiencies on the gluten-free diet, specifically certain B vitamins, and then also some other micronutrients. And while these deficiencies haven't really been shown to be different based on sex or gender, once again, these deficiencies can have more severe implications in pregnancy. And so definitely something that is pertinent to women. So in summary, the main take-home points from this presentation are that celiac disease is very, very common, and the only current treatment that we have available is a strict gluten-free diet. It is more common, almost 2 times so, among women. And while the diagnosis may be equally challenging among sexes and genders, there are aspects of the presentation, complications, and treatment that may affect women differently. And this slide is just to thank everyone on my team over at the Children's Hospital. It also lists the number for anyone who is worried about celiac disease and would like to make an appointment with our adult gastroenterologist colleagues over at UC Health. And then there was recently a wonderful column published through Beyond Celiac on this very topic. And so I included that link just on this last slide here.
Thank you very much. That was great. And I really appreciate it. This is, I've learned a lot tonight from about the three different diseases that were discussed. And it's so interesting that, and awful that one sex can get a disease more than another sex. And there's so much left to learn. One thing I was asked, I'll start with you, Kristen, was about hydroxychloroquine, which of course came to, got a lot of notoriety as a possible treatment for COVID, but actually is known to be a treatment for rheumatoid arthritis. Do you want to comment on that?
Sure. Yeah, I know it's a very charged medication these days. Yeah, it's a medication that's been around for decades, and we use it commonly in rheumatoid arthritis and lupus. Specifically in the doses that we use for treating those diseases, they're quite a bit lower than the doses that were initially thought to potentially be helpful in COVID. I think overall those studies have shown that they have not been helpful in COVID and potentially harmful. But for patients who get prescribed them for a rheumatologic disease, or even the doses that are used in the prevention trial, they're at doses that we use all the time that are safe and lower than those you may have heard about on the news a year or so back.
Thank you. Dr. Shah, why is multiple sclerosis more prevalent in different geographic regions? Are there thoughts about why that should be?
Absolutely. We think part of the risk factor is associated with amounts of vitamin D that are absorbed. One of the things that we know is the further away we get from the equator, individuals tend to have lower vitamin D levels. The way vitamin D works biologically is it does decrease some of the inflammation associated with multiple sclerosis. So that's one thought as to why there's certain geographic areas that multiple sclerosis tends to be more prevalent in, but we know it's not just dependent on that, because there are a lot of people with low vitamin D levels that never develop multiple sclerosis.
So food for more research. Dr. Stahl, question is, how common is it for celiac disease to develop later in life, like in your 50s?
So I think it's actually really hard to say that because there's a lot of people who have probably had celiac disease for longer and just haven't been screened. And so they end up being diagnosed later. That's actually a really controversial subject within celiac disease clinical care and research, because I think, we definitely do see people who are diagnosed later in life, but when they actually get celiac disease, we're not sure. And that's the benefit of increased awareness and increased screening would really be to be able to diagnose people earlier.
Kristen, if you have one autoimmune issue like Hashimoto's, are you more apt to experience others like rheumatoid arthritis or lupus over time?
It's a good question. I think it's a little bit complicated to say for sure, but there are some people who do have more than one autoimmune disease. Maybe there's some shared genetic risk between some of our autoimmune diseases, but it is hard to say. Particularly thyroid disease, sometimes we do see that in association with other autoimmune diseases. So it happens, but not all, it's not so common that we think of it all the time, but it can happen.
Here's a question for all three of you, which I think is really important, which is how can women be taken more seriously when seeking diagnosis?
I can
I'd like
start.
to hear from you three. Go ahead.
I think one of the challenges that women in the field that I see in multiple sclerosis run into quite often is a lot of the symptoms of multiple sclerosis can wax and wane, meaning that it can be incredibly significant at one period in time and then not quite so significant later on. So it leads to kind of, as a patient might say, I had these symptoms, but by the time I got in to see neurologists, because we're notorious for terrible wait times, by the time I got in to see a neurologist, my symptoms had gotten better, which I think can be quite challenging, especially in young patients. And I see it quite often in young women who are complaining a lot of fatigue or pain. I think one of the most important things is that regardless of what anyone says, you know yourself best and continue to advocate for yourself.
Other comments?
Yeah, I'll just add, it's a great question. I think it's hard. I'm just thinking too, postpartum, we see women develop rheumatoid arthritis and they say, oh, I'm tired, my joints hurt. And, sometimes people will say, well, you've got a new baby at home. I'm sure, you're picking them up and you've got carpal tunnel syndrome. And so I think advocating for yourself is definitely important if you know something's wrong. And hopefully we can, as, providers in these areas, continue to educate primary care providers, because that's often the first point of contact that patients have, and trying to continue to educate them about the signs to look for autoimmune diseases and other diseases, is something that we should be doing as well. But it's a great question, and advocating for yourself and awareness, I think, is really important.
Yeah, and I would echo that message of self-advocacy and increasing provider awareness as being very, very important for helping to identify these autoimmune diseases earlier, kind of going back to that question of how often is it diagnosed when people are 50 for celiac disease. And, some surveys that they've done have shown that there's on average a diagnostic delay of up to 10 years, because I think a lot of people kind of think of it as just this disease that affects the intestines, but then there's so many extra intestinal manifestations, and people just, it's not on their radar for the differential diagnosis for what might be going on. So I think, being able to advocate for yourself and saying that you want to be screened and these are the tests that you want sent, that is another great way to make sure that you're being tested if you're concerned about that.
I think it's really important at the Ludeman Family Center for Women's Health Research. We hear a lot about this type of thing where women with cardiovascular disease, which is my area of study, people come in, women go to their doctor with, it sounds like a pretty good story for heart disease, and they get sent away and are told often, not rarely, that they have psychiatric issues. Like, well, it's not too good then if somebody has a heart attack. Jennifer Ingleby, did you want to say something? says under the comment that you wanted Jennifer as the deputy director of the center. Let's see. Okay, I'm going to move on. Does hysterectomy alter the incidence, development, or severity of RA or lupus in women?
And not that has been reported or that I've seen.
Okay. Somebody asked the question about for MS about bioidentical hormones, also a controversial area. Can you address that?
Yeah, most of these hormonal studies, it's been a while since they've been done. So I'm not entirely sure if they used bioidentical hormones or not within the study. I think there is certainly a lot left to learn about the utilization of hormones as disease-modifying therapies, and multiple sclerosis certainly benefits, but they also come with some increased risks.
Yeah, my colleague, Dr. Nanette Santoro, the chair of OBGYN, is a firm non-believer in bioidentical hormones, saying that, you know, the hormones that you get prescribed by your doctor are the real thing. So just a word that is definitely controversial. What are the effects of losing long-term hormones as DMT, which I don't know what that is, for other autoimmune conditions other than MS, in particular Sjogren's syndrome?
I can answer that. I think I'm not aware of studies. Rheumatoid arthritis is certainly something I research more, and there haven't been associations with hormone replacement therapy and development of rheumatoid arthritis. I don't think I've heard that in Sjogren's syndrome that I'm aware of. So no connections that the research has shown so far.
People with type 1 diabetes often subsequently and sequentially develop celiac or Hashimoto's or Addison's. Do we know why a time course like that seems to exist?
Yeah, so in the studies that we have done with children who are at risk of type 1 diabetes and celiac disease, what we have seen is that it may be up to, in some studies, even 12% of children with type 1 diabetes who will get celiac disease. The thought is just the overlapping HLA risks for both of these autoimmune diseases. But in terms of environmental triggers as to what would cause you to have both, I think we're still working on finding that out. There is a lot of research in that area and a lot of interest.
Someone asks about her 10-year-old granddaughter who has both JIA and celiac, and she understands that this is a common comorbidity. Do you see adults with RA and celiac going hand in hand? And why do we see the JIA and celiac together so much in children?
Yeah, that's a good question. I certainly have patients who have RA and celiac, but I wouldn't say that it's a common overlap that I see clinically. JIA is probably develops differently than the adult version of rheumatoid arthritis. There's some differences that we see. And so there's probably some differences with genetics and the triggers of the immune system that lead to those. So my guess would be that there may be some just differences in how those diseases develop. But as we heard about today, there could also be screening issues. Our patients have a diagnosis of rheumatoid arthritis, and I don't know how often we screen them for celiac to look for a second thing. I think there's probably still some of that to be had in the adult population as well, as was discussed very nicely earlier.
And there is definitely an association between JIA and celiac disease within the pediatric population. JIA is actually one of the diseases that our pediatric GI organization recommends routine screening for celiac disease. And the thought is, once again, that overlapping HLA genetic risk for both.
For those in the audience who don't know what JIA is, do you want to tell them?
I'm not sure if the rheumatologist should answer. Maybe I should. Yeah, it's juvenile idiopathic arthritis, so an autoimmune arthritis that affects children, usually younger children. But
so another person in the audience, which is asking great and somewhat challenging questions, which is good, and keep asking. she came late to the meeting and is not sure if this topic is applicable. If you have Hashimoto's and hypothyroid, is a gluten-free diet recommended even if you don't have celiac disease?
So this is a really controversial topic.
Mhm.
I think there is a lot of people who are gluten-free, not for celiac disease. And there isn't a lot in the way of studies that support that. But with that said, there are definitely people who feel better being gluten-free, even though they don't have celiac disease. And what I would say in that scenario is that if you are gluten-free, I would highly recommend that you see a dietitian to talk about your diet, because it can naturally be lower in certain vitamins and minerals that you really need. And as we went over in the talk, certain vitamins and minerals that are very important during pregnancy. And so just making sure that if that is the route that you want to go and you want to be gluten-free and you don't have celiac disease, that you're getting the same education from a dietitian that we would recommend if you did have celiac disease.
That's good. It's very complicated. And I think in our society, a lot of people avoid gluten even when they have maybe not a clear reason to do so. It's kind of a thing. Do you see that also?
Absolutely. And, like I said, there aren't a lot of studies that will necessarily support that, but there are people who feel better being gluten-free. And if that's the decision that you want to make and it makes you feel better, that's fine. But just making sure that you have the right education to be healthy about the diet is very important.
Any other questions from the audience? If not, thank you. What a good discussion and great talks. And I really liked it. And I was also told by my staff, I thought that 150 was the average number of attendees, but it actually ranges widely. And tonight's 90 was a very good attendance. So nobody anguish over that. Okay. Thank you very much. I really appreciate you guys. Were great. And thank you all in the audience for coming to Let's Talk. Please stay tuned for our annual community event, which will be sadly but beautifully live streamed. Again, we were hoping to have our event live. We have an event for those who don't come. Dr. Demoruelle knows this, but for 800 people at the Sewell Ballroom in the fall. And that's not going to happen this fall, but we will have a live stream event. So we look forward to seeing everyone there, and tune in to our next Let's Talk. Thanks, everybody. Bye-bye.